So a couple of weeks ago, when I was on one of these, someone had brought up wanting to learn more about like some behavioral things for chronic pain management. It just so happens that I help run a program where we do that. So I reached out to Nicole and said, hey, let's try this. So I'm going to be presenting about a program that was developed at the VA that we have amended to work here in our clinic. We call it Living with Pain. I have no disclosures, but I see everyone put this slide up in presentations, so I did. So there we go. All right, so just a little bit of background. Like I mentioned earlier, I am an integrated behavioral health consultant here at Family Medicine Center. I'm a Coleman employee, but I'm contracted to work through SUMA. We're very involved with many patients. I've listed some here on the slide. Essentially, anyone who has any type of concern that could be mental health related, myself and my partner jumped in on those cases. About 4 years back, Dr. Smucker, I'm not sure if anyone is familiar with him. He passed last year. He read this VA curriculum and he came to us and he said, all right, I need you guys to develop this. And then he came to us a month later and said, why haven't you started? So this has sort of become a little project of mine that I worked on, and Living with Pain was born. So just to fill you guys in a little bit on the model here, the VA developed this therapy manual, Cognitive Behavioral Therapy for Chronic Pain. They run a 12-week session of CBT for chronic pain for, I'm assuming, anyone who wants to be involved with it. They obviously have a lot of patients who have chronic pain and then that overlap with mental health. And so they developed this program out of that. They created the manual to share with the general public because they found that the therapist and patient skill outcomes were enhanced by both of them using it. And it's all about developing that therapeutic relationships and helping the patients, take a problem-solving approach to their pain. So that's the background of where this came from. This manual is available via PDF form for anyone to download. You can get it right off of Google. And it's a really helpful, especially for any therapist on the call. It's a very structured layout. It's a 12-week session that they do. So the FMC model. So I work in a clinic that takes care of what we call LTOT patients. That stands for long-term opiate therapy patients. We have about 60 patients who fall into that category that our physicians prescribe for. And so what our idea was to take this curriculum from the VA and have every one of our LTOT patients participate in it. Now, we're talking about some people who, are elderly, or some people who are maybe a little crotchety about the role of mental health in their chronic pain. And so we kind of looked at that and said, okay, 12 sessions would be great, but I think our patients can handle 3. So what we decided to do was we kind of adapted that program to fit our clinic. Each patient in our LTON program receives a diagnostic assessment and then 3 sessions to help teach skills to manage and cope with their pain. Our focus in this program from the beginning of time that the physician starts prescribing throughout their treatment is all about function and quality of life. So I'm not going to sit here and pretend that behavioral health interventions can make a patient's pain decrease. That's not our goal. We're working on, can I help your quality of life improve? So I put a very poor quality picture of the Chronic Pain Association scale here. This is something we use with all of our patients at their physician visits, as well as follow-up visits with myself and my partner. And it asks just questions about where you're at with your regards to your function, your quality of life. So just a quick background. I know there's a lot of doctors on the call, but quick background on what we're actually talking about here. So chronic pain is pain that persists beyond the normal time of expected healing. There's no biological utility at that point for the pain. It's not really protecting them from further injury, versus acute pain, which is that physiological response indicating something is wrong, right? I touch the burner, my receptors go off, I'm in pain, I have to remove my hand from the burner. So that's kind of what we're talking about. The patients who we put through this program are going to fall into that chronic pain category. So I'm going to jump into sort of what we cover with patients. And this is just a good, thing to talk about with patients. A lot of times doctors and patients both feel really dissatisfied by chronic pain visits because the doctors feel really frustrated going in because they can't necessarily help the person, and the person feels really frustrated because they can't get the help they're looking for. So I thought this could be helpful just to have. So I'm just going to kind of run through our sessions and then we'll take it from there. So the first thing that we really teach people about is this chronic pain cycle. And what that is, it's a cycle between having real physical pain, becoming decreased in your activity, deconditioned, which leads to negative emotions, and in many cases leads to clinical depression or clinical anxiety. That causes the person to further withdraw and avoid, which further increases their distress and disability. Now, we know that this pain is ongoing. It's not necessarily something that we can just fix or make better, right? We can't necessarily make better the physical things that are going on, but we can play a role in those negative emotions. We can play a role in the treatment of their depression. We can play a role in teaching them the things that they can do instead of thinking about all of the things that they can't do. And for a lot of my patients, even just seeing this cycle can be very validating for them because it lets them understand, yeah, we see that this is causing real problems in your life. So we try to intervene within that cycle. One of the ways we do this is by touching on that first bullet point, the activity. So a lot of times people with chronic pain find themselves trapped into this cycle where they're either doing everything all at once or they're doing nothing. So I have a lot of patients report, oh, I had a really good pain day. So I cleaned my house and I went to the grocery store and I worked in the garden and I got everything done. And then the next day we see them completely crash and they can't get out of bed and they can't move. What usually happens is the days that they're doing really good, their pain is low. The days they're doing really bad, their pain is really high. What we try and teach our patients is instead of being in that cycle where we're having really large fluctuations, let's try and decrease our fluctuations by, doing some pacing. Hey, maybe instead of going to the grocery store, going to the garden, cooking your dinner, let's maybe just focus on going to the grocery store or cooking dinner or working in the garden. I'm a big runner, so I talk with my patients about the fact that when I start training for a marathon, I don't jump into 12-mile runs, right? I jump into 2-mile runs and I build up from there. So we have to teach the patients the skills so that, maybe before they could do all those things at once, but now that they have chronic pain, they can't. So we try and help flatten that curve and reduce those big fluctuations in their activity. The second thing we teach them is creating a flare-up plan for their pain. So we have to accept that flare-ups are going to happen. For the mental health practitioners on the phone, crisis is going to happen in treatment of depression, right? You expect your patients when they are depressed at some point in their life, they may feel suicidal. Now, would you want the patient to not know what to do when that suicidal thought comes up? Or would you want them to be prepared with a bunch of numbers that they could call and coping skills they can use when the suicide crisis comes up? Probably the second, right? So we walk through with the patients, okay, when I'm having a flare-up, because I know it's going to happen, what things can I do behaviorally to manage that pain? I put up some pictures of the most common things I hear patients tell me. It's heat, it's ice, it's Voltaren gel, it's stretching, maybe it's some PT exercises they learned at some point. Sometimes it's just staying in bed, though we do try to limit that. We don't want them to just resign themselves completely to being in bed. So those two things make up our first session, the pacing and the flare-up plan. We used to run this as a group. Now we do it individually because of COVID. And I didn't feel like teaching the Medicare population how to use Zoom. So those two things are the first session. And we'll move on to the next one next. Relaxation techniques. So the whole second session is focused on relaxation techniques that people can use to manage their pain. So it makes a lot of sense, right, to think about if I am having a lot of pain, my body might not be relaxed, right? One, if you're having tightness in a muscle, you might guard that muscle, you might tighten it up without even thinking about it. Yep. Two, when I have that tight muscle, I'm going to feel anxious or depressed about that tight muscle. If I'm not relaxing my body and I'm holding that tension in my shoulders, I'm going to start to feel more tense, which is going to feed back and make the pain in my shoulder feel worse. So we're working on it from both sides, right? We're working on it. Can you proactively relax your muscles so that maybe the pain buildup doesn't happen? And then on the other side, when you're feeling stressed or depressed or fatigued or whatever, can you relax the body? So this is oftentimes where I get the patients to be like, I don't really think that like just mindfulness or relaxation is gonna like make anything better. I need my meds, that's the only thing that helps. And I'm like, okay, but like, will it make it worse? Right? Like that's the technique I usually use. Like, is this gonna hurt anything? No, it's not going to hurt anything. So I teach two primary relaxation skills to my patients when it comes to managing their pain. The first is just a simple diaphragmatic breathing skill. You never believe how many people have never been taught how to breathe to relax. And then the second one is a progressive muscle relaxation skill. And I was going to run through that really quick with everyone on the phone because I feel like at noon, we can always use a little relaxation in our lives. So take a second to put your feet flat on the floor, put whatever you have in your hands down, put your back flat against your chair, kind of take your shoulders and bring them away from your head. If you're comfortable with shutting your eyes, shut your eyes. If you're not comfortable with that, you can gaze at, whatever's right in front of you. We're going to take one cleansing breath in through our nose and out through our mouth. And then I want you to turn your attention to your toes. And I want you to think about how your toes feel inside your shoes. And I want you to take your toes and I want you to scrunch them up and clench them and hold them like that. And then I want you to relax them. Next, I want you to turn your attention to your calves. And I want you to think about how your calves feel. How often do we think about our calves? And I want you to tighten that calf up, and then I want you to release it. Next, I want you to think about your thighs. And I want you to go ahead and tighten those thighs up and relax them. And then I want you to move into thinking about your hamstrings and your butt muscles. And I want you to clench that muscle and relax it. Next, we're going to move up to our stomach, which is a very common place that we hold tension. I want you to tense up that muscle like you're doing an abdominal exercise. Hold it and relax. For our lungs, I want you to take a deep breath in and feel your lungs fill with air and expand, and then slowly release that air. Next, I want you to think about your hands and all of the things that your hands can do for you. Take your hands and ball them up tight into a fist, and then relax them. Next, we're going to move on to our shoulders. And I want you to scrunch those shoulders up close to your ears, bring all the tension you can in, and then just release them and bring them down and back. And then the very last one's my favorite, but I want you to scrunch up your really tight, your face as tight as you can, and then just kind of like let it out and relax it. And then after you've done that, go ahead and open your eyes and rejoin me here in the Zoom chat. All right, so that's just a very brief exercise. You can amend it however you want. Sometimes I focus more on individual. If I know I have an individual who has back pain, I'm not going to have them focus on their back. I'm going to have them focus on other body parts. Sometimes I might want someone to become very mindful of all the different places that they feel. So I'll go through, your toes, your ankles, your shins, your calves, and feeling all of those places. That exercise is helpful on two fronts. One, hopefully you feel more relaxed than you did a few minutes ago. Two, if I'm able to practice attending my mind to different parts of my body, when I start to experience the chronic pain, I can attend to my body to the parts of the body that don't hurt. So again, example I use with patients is when I'm out on my long runs and I start to have some hip pain, if I keep thinking about the hip pain, it's not going to feel any better. But if I think about the fact that my feet are doing okay, sometimes I can distract myself away from it. Anytime I teach these skills, the patients never remember the deep breathing exercise. But they're like, oh, I remember that muscle squeezing thing. So it's helpful. All right. And then the third and final session is all about the C and CBT. So I know we have a lot of therapists on the call, and I know we have a lot of physicians on the call. I think everyone knows what CBT is, cognitive behavioral therapy, right? So it's that connection between thoughts, behaviors, and emotions. The thoughts that I'm having can contribute to any emotions that I'm feeling. The emotions that I'm feeling contribute to my behaviors, okay? When we do CBT for people who are depressed, we look at whatever automatic negative thoughts they're having that are contributing to their depression. We help them challenge and reframe those thoughts, which hopefully helps relieve some of those depressive emotions, okay? So when you talk about what we've worked on so far, we've worked on the behaviors, right? We talked about pacing. We talked about a flare-up plan. We talked about relaxation skills. I usually work with people on the B first, both when I'm doing chronic pain and when I'm doing depression or anxiety, because the B is a lot easier to change, right? It's a lot easier to change our behaviors and replace our behaviors than it is to change our thinking. Particularly with chronic pain patients, we have a really, really big difficulty in helping them grasp this concept. Part of it is because of how severe their thinking about their pain is. So catastrophic thinking will also reinforce chronic pain, okay? They might be misinterpreting the signal that it means something is really wrong, or this is going to hurt me worse, or this is never going to go away. When they have those thoughts, that actually makes their experience of pain worse, because they're so fixated on the negative aspects of their pain. They've forgotten all about function, they've forgotten all about quality of life, and all they're thinking about is how much this pain hurts. We use this, it's called the PCS, it's the pain catastrophizing scale. Again, very small because I have very poor pictures, sorry about that, but also available pretty easily to find. This kind of helps assess whether or not patients are having some of the poor cognitions about their pain. So if I just ask patients, hey, what are your thoughts about your pain? I usually get like, why are you asking me that? My pain's horrible. My thinking has nothing to do with it. What are you talking about? And it doesn't go anywhere. When I give them this scale, it specifically lists off thoughts that they might have. So I'll read a few of them for us since it's so small. I worry all the time about whether the pain will end. I feel like I can't go on. It's terrible and it's never going to get any better. It's awful and I feel that it overwhelms me. I feel I can't stand it anymore. I become afraid that the pain will get worse. I keep thinking of other painful events. Okay, those are just the first few. Then it asks the patients to rate, do you feel this way a little bit or do you feel this way all the time? Okay. Sometimes I'll have patients be like, I have no idea what you're talking about, my thoughts. And then I'll pull this out and I'll be like, hey, remember when you wrote this down, you identified with, I keep thinking about how badly I want the pain to stop. You said that you had that all the time. That's an example of a cognition that's catastrophizing how bad your pain is. Typically with these patients, if I can get them to take a step back and challenge that thought, right? I keep thinking about how the pain will never stop. If I can get them to take a step back and say, okay, well, yeah, I feel like it's never going to stop, but then sometimes I'm able to use my gel or put a heating pad on or chill out for 20 minutes and my pain goes from a 10 down to a 7 and I can handle a 7. Then I say, look, that's an example of a time that it stopped, right? So we're really focusing on changing some of those cognitions that the people are starting to experience. But this is probably the most difficult thing to do with patients out of this whole program that we run. So how do we do that? Again, there's a lot of therapists on the call, right? We do this using a traditional thought log. We want to help them challenge the thoughts. We want to teach them to reframe their own thoughts. Sometimes we try and teach them, hey, yeah, you can't do this, but what can you do? Trying to help them reframe to think more about their function and less about their pain. And then finally, the last thing we do, we focus on lifestyle changes. So if you think about like Maslow's hierarchy of needs, right? Everything we've been talking about before is kind of like baseline stuff. Can I handle my pain flare up when it does come? Can I relax my body? Like those are those like more basic things. We start to get a little higher with the cognitions and helping them change that. And then I kind of view this as like the top level. Like if I can think about ways that I can change my lifestyle that might impact my pain in a positive way, that's amazing, right? That's a huge change. So, you know, we talk about lifestyle habits, approaches to different situations, ways of thinking, other changes. The goals might range from anything from like unloading the dishwasher. Like I have a patient who literally could not unload her own dishwasher and she wanted to brushing her hair. I had another patient who wanted to start volunteering at an animal shelter. I had another patient who wanted to start wearing makeup every day to help improve her self-esteem. These goals can really range all over the place. Sometimes we're able to gear these things to things that might actually help reduce their pain, you know, sometime in the future. Self-disclosure, when I was like in my early 20s, I was experiencing severe back pain from like slip discs and things like that. I was prescribed tramadol, and now looking back on it, I'm like, holy crap, like, whoa, how did that happen, right? I ended up losing about 50 pounds and my back pain went away. Now, that's a pretty simple example, right? Because I'm a healthy, young, well-off, not a lot of barriers woman. So that's maybe unrealistic for some of these patients. They might want to focus on, I want to learn how to eat better, or I want to go to water therapy so that I can move my body a little easier. And every once in a while, maybe you'll get a patient who was like, let's talk about some lifestyle changes that can really help and go from there. So that's the last thing that we teach the people in their group. So I think I went over everything, sort of how the whole structure is. All of this came out of that VA handbook. Also added some little stuff here and there from different trainings and things like that we learned. Our patients are required to do this every year. So they come back to me every year. We redo that DA, see if there's anything else going on, go through all of the sessions. Sometimes they decide they want to stay on for more treatment and we can address some of their underlying issues, and that's great. Other times I'm like, see you in a year. So yeah. Any questions about any of that program?